that the role of the CIO has changed totally. You know, we were software developers and architects, and we could tell you what RAM to use based on its transactional speed. Do you think any of that matters anymore? The answer is no.
Welcome to This Week in Health IT, where we discuss the news, information, and emerging thought with leaders from across the healthcare industry. My name is Bill Russell, recovering healthcare CIO, writer, and advisor with the previously mentioned Health Lyrics. I was the CIO for a 23,000 person health system, and one of the biggest challenges was to remain current on the technology and the trends that were going on myself.
Think of artificial intelligence as a orchestra. Right now, machine learning, deep learning is getting a lot of attention, so I sort of equate that to the string section. And obviously there are many sections to the orchestra, so someday soon, hospitals, healthcare organizations are going to be able to have amazing music.
We are seeing instances of folks popping up, us included, where we're having a primary care physician set up with the dentist in the same office.
I would love to get to the space where eventually we're using voice recognition to do all of our navigation throughout the electronic health record.
When we worked at Microsoft, oftentimes, you'd have crazy deadlines. People would say, look, we're not saving anyone's life here. We can't say that anymore. And we love that. It's like we can save someone's life. We can prevent a complication or a readmission by catching it.
A lot of the feedback people are hearing about former Vice President's remarks is that he was remarkably pragmatic. And then the one that I'm most excited about, he notes that the Medicare Innovation Center, which was created by the Affordable Care Act, has the legal authority to experiment with new models to engage patients for purposes of getting better value care.
Hyper-consumerism driving everything to a digital experience, because if we don't make it easy for patients like ourselves to use healthcare on our smart devices, companies like Apple are starting to do it for us.
I think we're right on the cusp of a huge digital transformation. It'll be interesting to see how CIOs sort of address that. Welcome to This Week in Health IT, where we discuss the news, information, and emerging thought with leaders from across the healthcare industry. This is episode number 31. Today, we take a look at the CMS Final Rule, and we discuss Apple's healthcare initiatives in more detail. This podcast is brought to you by Health Lyrics. Health systems are moving to the cloud to gain agility, efficiency, and new capabilities. We've seen health systems deliver 30% reduction in IT operating costs, reduce server provisioning time from 2 weeks to 5 minutes, and increase uptime and customer satisfaction in the process. Work with a trusted partner that has been moving health systems to the cloud since 2010. Visit healthlyrics.com to schedule your free consultation. My name is Bill Russell, recovering healthcare CIO, writer, and advisor with the previously mentioned Health Lyrics. Before I get to our guests, an update on our listener drive. Our sponsors have agreed, as we've talked about before, to give $1,000 for every additional 100 subscribers to the podcast, either iTunes, Google Play, or YouTube channels. We have 2 more weeks to go. If we just get 5 more subscribers, we will have raised $3,000 for Hope Builders, an organization that provides disadvantaged youth the life skills and job training needed to achieve enduring personal and professional success. I've hired their graduates. Their stories are really inspiring, really amazing. If we get another 105, we'll raise $4,000. So we've got 2 more weeks to go. Join us by subscribing today and be a part of giving someone a second chance. So today we are joined by a CIO who's been at the same health system for almost 14 years, which is amazing in and of itself. A leader in the industry and an advocate for health IT, the CIO for Intermountain Healthcare, Marc Probst. Good morning, Marc. Welcome to the show.
Morning, Bill. Good to talk to you.
We've got a neighbor right across here doing some weed whacking. So if that gets in the way, just let me know. I'm actually broadcasting from outside today. It's a little different. Man, you've been at the same health system for 14 years. I bet you a lot of CIOs would like to know what do you attribute that to? How have you been able to do that?
Oh, I think, Bill, it's working for an amazing organization that's really been forward thinking and not trying to screw up too many of the things that were already in motion. But we have changed a lot. I mean, we were completely self-developed for about 40 years, and we just replaced all those with Cerner and Oracle, PeopleSoft, and some legacy or some off-the-shelf products. But I don't know, longevity. I think it has to do with the ability to work with others, you know, not be a know-it-all, and keep my head low when it needs to be low.
Yep. And relationships are the key there, and a great forward-thinking organization also. And then obviously doing a great job. I realize you wouldn't say that yourself, so I'll just say it. You know, the making that transition, that was a huge transition. You guys had a homegrown EHR for many years, and then it just got too unruly towards the end, right? It just got so big and so massive, it just didn't make sense to try to keep maintaining that. And so you went out and did your RFP and ended up with Cerner.
Yeah, I mean, we'd really built applications to support the clinical and the financial functions, but not really to automate them, but to support with automation certain aspects of the caregiving process. And when meaningful use came out, and as technology, you know, really got much better, Help, which is our long time electronic medical record, was, you know, ASCII, green screen, you know, very, very fast, but mainframe based. And clinicians were looking for a lot more from the system. And to rebuild that, well, we tried with GE for about 6 years, and that turned out to be just too heavy of a lift. So we did go with Cerner, and it's been good.
Good. Well, that's great. Well, let me share a little bit of your background. So you've been obviously there for a while, 30 years in the industry. Prior to Intermountain, you were with Deloitte. So you've been with Deloitte and with E&Y. So you've been with two of the large firms, and you've been a CIO for a TPA as well. And we'll talk a little bit about this. So past board chair for Chime and the Chime Foundation, member of the original HIT policy committee in the early stages of meaningful use. So we're going to talk about both those topics. You're walking the halls of the Hill and what that was like, and we'll talk about meaningful use a little bit in our first story this morning. Resident of Utah for the past 21 years, Salt Lake, I assume.
Yes.
And you've lived all over. So you've Virginia, Tampa, grew up we've talked earlier. You grew up in Pennsylvania, had some time on the main line of Philadelphia as well. So you're married, have 5 children, older children. So you've actually made this transition from children to you've done the college tours and whatnot. Any words of wisdom for me as you can see, I'm off today. I've got the college hat on. I'm taking my daughter to college tours. Any words of wisdom of how to make that transition successfully?
Oh, I would say get a bunch more subscribers and watch your checkbook pretty closely. They definitely don't get cheaper as they get older, but they get better as they get older.
Yeah. Well, we don't make any money from the podcast. But, you're the second person who sort of intimated that and asked me that this week. This is really more of a public service thing of just getting you guys on the line and asking you questions and giving the benefit to as many frontline staff as can get it. So one of the things we like to do is we like to open it up to our guests before we start the show and just say, what are you excited about? What are you working on today? And just give you the floor. So what do you got?
Man, I got to tell you, Bill, what I'm excited. So I'm in the latter part of my career. I do have older children, and I'm older because I have older children. And I am so excited. I think it is such an amazing time to be involved with technology in healthcare. And having been a CIO, and whatever that role turns out to be in the long run, there's still CIOs will be leaders in what we do in technology, I believe. And I'm excited about the confluence of so many technologies right now, and the potential that has, not to just help healthcare, but to absolutely change it, improve it, and probably save it for our country and globally, I suppose, if you want to think that way. I mean, if you think about artificial intelligence and the potential that has as it gets coupled with the cloud and all the data that exists, as it gets coupled with what we're doing around interoperability, as it goes mobile, and with the power that we now have with the mobile devices. And I see a day from the consumer perspective where Dr. Google or Dr. Apple or whatever we want to call it is there. That's where they're going to go for their initial primary care, is going to be the device and all the knowledge that device has. That's going to help healthcare because we don't have enough clinicians to start with. and it'll really help focus what they do, and it'll be way more real time because, well, crud, we're all wearing monitoring devices, and we're learning a lot more about ourselves. The human body is actually becoming its own platform for computing. So I'm excited on that side. I continue to look at the confluence of capabilities. I look at what we're doing around natural language processing and voice, so Nuance and some of the companies that work in that space. We have been working with Stanford around computer vision, actually teaching the computer to see. So think about the triad of the computer being able to see, computer being able to hear, and artificial intelligence. Can we create Jarvis? Can we create what was in Iron Man 3 and just have the clinicians do their job and ask the computer for support? And we'll do all the documentation and all the dirty work behind, which is what we should be automating. Because to me, today, we don't facilitate care with technology. We facilitate creating a record. We get the information to clinicians that's a little more useful to them, but we don't facilitate what they do day to day. In fact, we get in their way, and we hear that all the time. But again, this confluence of so many new technologies that are at the very heel of the hockey stick. These things are going to take off. I mean, we all know they're going to take off. I'm not telling anybody anything they don't know, but it is so exciting. And I think I'm going to witness in kind of the twilight of my career an absolute shift of how technology is used and helps what we're doing in healthcare. So I think that's really, really exciting. And it's a great, like I said, it's a great time to be a CIO in healthcare.
Yeah, I agree. In the next decade, you're looking at precision medicine and what it can do, and that's just amazing, and nanotechnology and whatnot. But in the short term, we're not that far away from being able to interact with the computer by just saying, I mean, we're already doing it with our phone, but just saying, hey, Cerner, open up the medical record. Hey, tell me what my schedule is today. All right, give me the vitals on that patient, and all that information just coming back to you and potentially being spoken back to you. So you're actually interacting with a computer more like what we, envisioned all those years ago. This really is an exciting time, and I think we're going to see just exciting things in the next couple of years, and then in the next decade, I think we're just going to see advances that are really going to make our lives, fundamentally better as we move forward. So yeah, it is definitely a fun time. Let me transition. So we do two things on the show. We do In the News, and the second is we do Soundbytes. In the News, we each pick a story and we discuss. So I picked the obvious story for this week. I'll be the every week there's sort of a story that just sort of drops out and you just have to do it. So CMS proposes the final rule for the Promoting Interoperability Program. Let me read a couple things here. So today, CMS finalized the rule to empower patients and advance the White House My Health E-Data initiative and the CMS Patient Over Paperwork initiative. This final rule and others issued earlier in the week will help improve access to hospital price information, give patients greater access to their health information, and allow clinicians to spend more time with their patients. So if you break those three things down, you have, while the agency previously required hospitals to make publicly available a list of their standard charges or their policies for allowing the public to view this list upon request, CMS has updated its guidelines to specifically require hospitals to post this information on the internet in a machine-readable format. And I suppose that's mostly for organizations that want to start creating comparison apps and those kind of things. You just download that and look at it. And we'll talk about that a little bit. And then the final rule also reiterates the requirement for providers to use the 2015 edition of the Certified Electronic Health Record technology in 2019 to demonstrate meaningful use to qualify for the incentive payments and avoid reductions in Medicare payments. And then finally, the final rule removes unnecessary, redundant, and process-driven measures from several pay-for-reporting and pay-for-performance quality programs. CMS said it eliminates a number of measures acute care hospitals are currently required to report across 4 hospital pay-for-reporting and value-based purchasing quality programs. And it duplicates certain measures that are multiple programs. In all, these changes will remove a total of 18 measures from the programs and deduplicate another 25. CMS said its changes in hospital quality and value measures will eliminate more than 2 million hours of work, saving providers almost 75 million annually. So that's a high level overview of the final rule. So let's just start with a pretty open-ended question. So what's your initial reaction to the final rule?
Directionally correct. It does show that the current administration, CMS, even the White House, are listening to some of the things that are being asked of them from people like Chime and us as a voice, as a healthcare community. So I think directionally, very good. I'm happy that they're making some changes, but it's excruciatingly slow in getting to the actual solutions that we need, is what I believe. So again, and if you want some context to that, Bill, I mean, I was part of the HIT policy committee, and our job was to define meaningful use. I won't go into the nuts and bolts of that, but it was a fairly liberal group, and I'm a pretty conservative guy. And I think what we did, although again, the intentions were correct, it really wasn't an healthcare improvement bill. It was really part of the stimulus package. So, the intent was to get more out there. But through meaningful use, we created such a rigid structure that what it ended up doing was really tamping down any kind of innovation. It didn't help interoperability very much. And what I like today in the final rule and what you outlined is that it is minimizing some of the rigidity that was in meaningful use, but still trying to get some of the benefit of technology out there and incentivize people to use that technology correctly. We don't have enough focus, and I'm a one-trick pony when I go to DC. I pretty much talk about the same thing, and that's standards. And I think we're excruciatingly slow in getting to standards within our healthcare environment in the United States, and that's hampering a lot of the benefit that CMS and the administration are trying to get. But I am happy with the rule because, again, I believe it's directionally correct and easing some of the burden that meaningful use and some of the programs have put on us as providers and us as a healthcare community.
Yeah, and I think the one of the things I've heard over and over again is the meaningful use got much more directive in 2 and 3. So in the first one, it was directional. It said, here's directionally where we want to go. And in 2 and 3, they really expanded on that and told you exactly how they wanted it done. I think this goes back to that directional. It's not telling CIOs and health systems and EHR providers, this is exactly what we want you to do. They're being much more open. But I want to touch on that, and just a case in point. They're not saying, hey, this is what the EHR has to look like. They're saying, we're removing these measures. Okay, now go practice. And the 2015 rule is really mostly about APIs. And it's saying, all right, here's all we want you to do is we want you to make that data available so that other systems can inhale it, use it, and make it readily available, not to be captured and in the confines of the EHR or the provider. We want it to be accessible and interoperable. So they're getting directional again. But what do you say to those people? So this is the thing I've always struggled with. There are people who say, hey, CMS needs to set the standards. CMS, we're not getting enough direction. But on the other hand, we have those same people will say, too much government oversight. They're telling us too much and those kind of things. We just want to practice medicine. I mean, it is such a fine line to walk to say, do we really want the ONC setting what kind of standards? Do we want them setting data standards so that data will flow more freely? Do we want them to set EHR standards so that one EHR to another will be pretty standard for a physician? They can go from a Cerner shop to a Epic shop to a Meditech shop and be able to practice medicine pretty readily because it's common. What kind of standards would you look for from the government versus just let us alone and eventually healthcare, we will work it out?
Okay, so I come from the reddest state in the nation, which is Utah. And I mentioned earlier, I'm pretty conservative. I have to tell you though, when I go back to DC and I talk standards, I think the government needs to define data standards so that we can get to a level where it is truly fluid data that's moving between the systems and it means something. even using FHIR and some of the API work that we've been talking about, and frankly, we've been using for quite a while and pushing here at Intermountain, it doesn't get to a level of specificity where you really have this fluidity of data and where it can be used and computed. So what we'll do is we will get more data into the hands of the consumer, which is good. There's nothing wrong with that at all. We'll get the ability to shift data between systems or health systems or hospitals, but it won't be readily computable. So either we're going to have to go through some pretty challenging work to get that normalized into the system so that it can be consumed by the computer and provide insight that our clinicians are looking for, or I think they're just not going to look at a lot of it. And it's likely to be the latter. They're not going to look at a lot of it. It's funny, and you can stop me whenever, Bill, but probably 5 years ago, I went out and I did 23andMe. I was going to go out and get to some of this precision medicine, and I was going to understand more about my DNA. And I went and I did it, and it wasn't all that insightful. Took it to my physician. He didn't even want to look at it. He didn't even care. And it's because it's not relevant to what they're trying to accomplish. We're giving physicians, 8 minutes on average to deal with a patient. They don't have time to consume this stuff. It has to be brought to them in a meaningful way. And so I'm a big proponent of the government being much more aggressive in defining standards and putting it out there for us. Now, there's a lot of things around that and how we use the data, how our systems look like, how we present it, how we do AI and those kind of things that would actually be facilitated if the government would get to that basic standard. It's like the government tells us how to build a road, speed limits and those kind of things, but the cars that are on it, there's regulation, but they're able to consume that. They're able to use those things because the government took care of the basics. I don't think the government's taking care of the basics, and I'll readily admit it's really, really hard. It's not a simple solution, but it's the right solution, and I will continue to purport that in my discussions.
Yeah, and the thing I always say to CIOs is you can start this work today. I like to start with transparency for two reasons. The first reason I like starting with transparency is it's such a great foundation to sit in front of the physicians and they go, why can't we get to this? And then you give them transparency into the data and they go, oh my gosh, this is crap. And you go, okay, you know why it's crap? It's because we need to start internally with data governance across our medical group and our acute care facilities and our long-term care. We need to get our house in order so that a CBC is a CBC is a CBC across the entire system. And they get it. As soon as they see it, they get it and they go, yeah, we need to do that. On the flip side, one of the most underused people in data governance is the patient. And it's interesting when you start putting that data out there and the patient can consume it, they can easily look at it and go, I don't live at that address anymore, or I never had that test done, or that's not me. Now, all those things are some of those things are a little scary. It's like, hey, you're giving the wrong information to the wrong person. But if that's what's reflected, if what you're giving the patient is what's reflected in your system, you're going to uncover a problem that could potentially lead to a medical error later. So that's why I like the interoperability that they're doing. I like the transparency to it because I always think that transparency is the beginning of transformation, usually.
Yeah, I think that's great. Well put.
All right, so we'll transition. Let's go to what's your story for this week?
Well, I know last week you talked about Apple and the hiring that they're doing, and that is actually when we communicated earlier, what really came to my mind as something that I think is really interesting in the press right now. They're hiring physicians, they're aligning with providers on the provision of care for taking care of their own employee base. And I do think it's interesting what they're doing in opening up their system for healthcare. And we're actually involved in that. I don't know if it's trial, pilot, whatever. I mean, we're doing some work in that space, not a ton yet, but we're involved in it. But I'm really interested in the changing dynamics of healthcare that people are taking. Think of the Buffett and JP Morgan, and I'm going to miss one, Amazon, and what they've put together around. They're going to go after healthcare, and they just hired Atul Gawande, right, to lead that effort. All of the and so the Apple article in and of itself that you've already talked about is interesting, and what I was interested in, but it's really more the broadening of how healthcare is being provided across the industry and how it impacts us as the provider organization.
Well, let's talk about one that's probably hitting your area. So you have CVS in Salt Lake in your area?
We don't have CVS. We
You
have
don't?
Walmart and
Wow, interesting. So you don't have to deal with this one. So CVS announced this past week that they're expanding their telehealth initiative, and I think some of the other players are probably going to come into your market and do the same kind of thing, right? So they're going to you're going to have the blurring of lines between who's the first point of contact. Do you go to your employer clinic? Do you go to your pharmacy-led telehealth initiative? How are you guys preparing for potentially new partners and new directions that people are going to come into your health system?
I wouldn't say we have it solved. We are in a fairly unique situation. In Utah, we're by far the largest provider of healthcare in the state. A little over half of it's provided by Intermountain Healthcare, and an insurance product, we're the largest insurance product for healthcare in the state. So we have some unique, that you're not going to find in New York, right? That kind of situation. You have a lot more competition. And so people like, it wasn't CVS, but one of the grocery store chains really wanted to get into the retail clinic healthcare. They came to us to work through it, and ultimately they didn't implement it. But I think right now we're okay because of our size and the stature that we have. But if United wants to come in here and make a play, or a CVS, who's a huge player, wants to come in and make a play, we're going to have to figure out and we're talking about exactly the problem you're talking about, Bill. What's going to happen? A lot of this primary care, a lot of this urgent care work is simply not going to be controlled by us any longer. When you have people with $6,000 out-of-pocket limits that they're going to have to hit, and they can go to CVS for $39.95 and have an interaction, or they can go to their iPhone and do it for next to nothing. That's what they're going to choose to do. What we need to become then are the specialists that they can't do over the phone. Pretty tough to do a prostate surgery, over your iPhone. I suppose we could figure that out someday, but I'm not going to try it. Pretty hard to have your annual physical where you have to be touched over the iPhone. So we're going to have to become better at what we do. We're working a lot on access. So where the hours used to be 8 to 5, the hours now start at 6:30 and go till 9, because that's what our consumers want. And we're no longer going to be able to direct them as well as we were able to in the past because of all these options. I think that's great for the consumer, by the way, a little harder on our clinicians, but great for the consumer. So we're just going to have to change our access methodologies. I think we're going to have to become more specialist focused, because that's what they're going to need to come to us for. If they can get the answer to their otitis media for their 3-year-old, either over a telehealth visit or through their iPhone, then they're going to do that. But there are things that we'll be able to do that you can't yet, and probably never will be able to do over those technologies.
So I do want to talk to you about the Apple Health iPhone app and the work there. But the last thing on this before I go there is, so telehealth can be, we talked about it sort of defensively, like who are you going to partner with? How do you keep other players from coming in? But it can also be an offensive strategy. And I think we've noted on the show before that you guys have launched I think the terminology is digital hospital, where it's essentially virtual hospital. And so you're overseeing intensive care units and those kind of things across the market, but you could also launch a telehealth program across states that you're looking to get into or looking into the future of getting into out of that as well. Are you guys, well, I mean, not to reveal strategy, but do you think health systems, let's talk this way, do you think health systems will start to enter markets that way, that they will enter first through these convenience plays or these convenience options, and then start to stand up clinics, and the physical infrastructure will follow after they've established a base?
Yeah, absolutely. That's happening and will happen. We're doing it. We haven't built any clinics clinics out of state, but we currently provide a lot of telehealth, again, kind of specialty things that they may not have in some of these rural areas or in Montana or Wyoming and some areas that we serve. Interesting, we use telehealth to provide some care in Alaska, and it was incredibly successful. There was an Alaska law, and don't take this as gospel, but I'm pretty sure this is correct, what I'm going to tell you. There was an Alaska law that said if the care couldn't be provided in Alaska, it had to be provided in the next closest US state. Well, that would be Washington, right? And through the work we've been doing in telehealth, because our costs are so competitive for actual care, and our care quality is high. This is primary children, so our children's hospital. We actually were able to, we didn't, but Alaska changed the law so that the patients could come to Salt Lake City and go to our children's hospital. So I think that's an absolute strategy, a really good one, and we will continue to deploy that. Our CEO has said a number of times, Mark Harrison, that we really don't want to build a lot more capital asset buildings out there. But if we can do this virtually and really be helpful to the communities we serve and the communities outside of where we serve, we want to be able to do that. I think we'll be doing it not just in neighboring states, but internationally as well.
Yeah. So today was the final day of ONC's Interoperability Forum, and one of the big headliners was Ricky Bloomfield, Apple Health IT, a physician who works for Apple, and he demoed their Apple Health app. And let me just read a little bit. So Bloomfield took the audience through all the cool nooks and crannies of the iPhone app, mainly its ability to vacuum up medical data, to an appreciative audience with their oohs and ahs. It's a real fire app, not a pretend watered down app, Bloomfield said. Another entry into the ongoing conversation over fire that's been moving past simple boosterism. I'm tremendously optimistic about health IT ecosystem today, he continued, crediting the work of tech pioneers and some of the regulatory and legislative efforts that have been opening up the data. So you guys are a part of this beta program. There's 80 some odd systems now that are participating in the beta program, which moves data out of the EHR through FHIR, obviously a limited data set, but through FHIR and into the Apple Health app. Can you give us a little bit of an update, or just anything on how that's going, or what your thoughts are?
Well, it's going well. We also would share in Ricky's approach and beliefs that having that data. I won't say we have any appreciable apps built right now or uses by our consumers, but directionally, again, we like the strategy. We're able to use the technology, so we've proven we can take FHIR and we can move data to those apps. So I think we'll start to see development and improvement in that area really soon. But I don't have anything to point to and say, Bill, hey, look at this great thing we're doing.
Yeah. And I think part of that is just the, this is still early on in the process. FHIR's still early on in the process, so we need to expand it to other data sets. And Apple's still new obviously still a beta program. So, but I agree with you directionally. If you get that data into that central repository, open it up to the app development store, and all those developers can start to access that data and utilize it. Obviously, it creates a whole bunch of questions for physicians, and in the back of my mind, as I'm even saying it, it creates some questions. But I'm sure that there's, I like the fact that you have a physician who's at the helm there, who's aware of some of the issues of people misinterpreting data or putting the wrong data out there. So,
yeah.
All right, so let's transition to Soundbytes. So Soundbytes, I have 5 questions, 1 to 3 minute answers. Don't feel the need to go into a volume on it. Just just what's out the top of your head on these things. So the first question I have for you is, you've been an advocate for easing the burden on physicians and patients. How have you seen technology be used to reduce that burden?
Yeah, and I think I started that when you asked me what I'm excited about, what's happening in technology. I really believe our ability to capture information, not through traditional keyboards or poking on a screen, but through voice, through image, through all these other capabilities that we have, that's going to be the biggest burden easer for our clinicians that's out there. And then what we do with that data, once we've got it into computable data, we've got all kinds of options. But getting the computer out of the way of the clinicians or the consumer and making it just a facilitator of what they're trying to do, that's the win here. And
so
honestly, I mean, I never thought we could teach a computer to see. Not when early in my career. We can, and it's amazing what you can do when you have some of these new capabilities.
So it's two directions, right? It's getting data in. So you see advances in helping us to just get the physicians to get the data in a lot easier, and then getting the data out. So one of the things I've heard from physicians over and over again is, look, I've got to go to 6 different screens to get a complete picture. And that's where we're going to see a lot of advances in the next couple of years, is really consolidating that overall snapshot so that they can get that information very quickly. And also just getting the information in is going to be a lot easier.
Yeah, so I mean, technology it's really interesting where we're at. We think of the EMRs. The EMRs are fairly old technology. I mean, they've done a good job, Epic and Cerner and all the providers, in refreshing some of the things that they're doing and modernizing some of the look and feel. But the baseline is they're older technology, right? I mean, they're like me, they're older. Doesn't make us irrelevant or bad, it just makes us older. But some of the new technologies that are coming out today and our ability to be able to feather that into these core processing systems, pretty exciting. And like I told you, I'm really excited about the future.
Yeah, absolutely. Your CEO is actually one of the CEOs I love to listen to at the JP Morgan conference. And he shared that Intermountain has partnered with Medicaid on a specific zip code that is sort of an underserved or a market with, just generally poor health for various reasons. But you guys have partnered with Medicaid, have assumed risk, and regardless of if those reasons are, it's a food desert or other issues, you guys have partnered with them. Can you give us a little bit of maybe background on that, or how IT is playing a role in that initiative?
Sure. So, our main office building is in downtown Salt Lake. And if you go up to the 22nd floor, which is our top floor, it's not the top floor of the building, we don't own it, but you go to the 22nd floor, and if you look out to the east, so you look out the windows that face east, you got the Wasatch Mountains, and they're beautiful, great skiing up there. And then if you walk to the other side and you look at the neighborhoods that are going to the west, there's a massive differential, even in our estimate, the mortality rate between those two vistas. Out to the east, very wealthy population, very educated. The University of Utah is up there. A lot of, it's just a really good demographic. You go out and look to the west, you have a different demographic. And I believe it's like 10 years is the difference in mortality rate between those two areas. So that's really, I don't know that that's exactly what got Mark Harrison thinking about it, because he's pretty wise anyway. But it is a stark reality that there are things we can do to improve the healthcare across our community, and that we have a responsibility to do so. So we brought in a gal. She actually already worked for us, but we made her a senior vice president over our community care. Her name's Mikkel Moore, and she's done an excellent job in aligning us with Medicare, aligning our own insurance products, aligning the delivery of care. And all of this requires technology, as you might understand, underlying it. The data requirements to even understand those demographics and the difference, the hotspotting that exists in there. So we had a lot of analytics involved in it. Yeah, there's a lot of technology supporting it, but really it's a moral issue that, just because you live to the east of our building shouldn't make healthcare better than any other area of our state. So we're learning a lot. We're learning a lot. We are immensely committed to value-based care as an organization. I think we may be one of the leaders in the country in actually taking on risk, not in sheer numbers, but certainly on a percentage basis for the population. We have a much smaller population than a lot of states. But from a percentage basis of the work that we do, we have really moved a lot into value, and that's caused us to build new tools, new data warehouses or data lakes, and the analytics that support it. So it's been very good for us to take the challenge that Mark Harrison laid out at the JP Morgan conference.
Yeah, and I think health systems that assume risk in any way, shape, or form. I know in Southern California we had about 250,000 lives at risk, and we had Sharp on. They have a lot of lives at risk, and you have a insurance product. UPMC has an insurance product. When you take that risk, it really does sort of help to get you the investments you need to put the technology around that, because the numbers tell the story, and it's pretty apparent. Intermountain is considered a pretty forward-thinking health system, exceptional results. Talk about how you get ahead of the curve. Specifically, how do you set technology, and when does technology lead? Because I know that gets kind of iffy. When does technology lead, and when does technology really just sit back and support the strategy? You tell me what we're trying to do, and we'll find the technology, versus, hey, you know what, this is a technology that's probably something we need to start playing with immediately because it's going to change things.
Yeah, early in my career, we were the guys that did that, right? We surfaced, and look at these cool new things called keypads and CRTs, and bring those into your system. We looked at some of the early EMRs and said how to bring them in, and it was all driven by us as geeks, as technology guys. That that's what interested us, and most of the providers and most of our business partners, they didn't think that way. They were still using Selectrix and a lot of manual process. And that's not a negative. They were doing a really good job with the tools that they had, but we were interested in it. Well, that's completely turned around from my perspective, Bill, where they actually know more about technology, at least in their specific areas, than I'll ever hope to know. I'll stay interested. I'll try and stay on top of it. I will go learn things and go to conferences and look at podcasts and learn things. But but they are really the ones they understand everything about technology. I don't have to teach them how to use a mouse. I don't have to teach them how to use an iPad. They've got that because it's embedded in their everyday lives. So I think, to answer your question, in an innovation perspective, in maybe, I'm really interested in AI, and I am, so I'm going out and doing a lot of research. I can lead to bring those ideas to management and what we might be able to do, and then try and secure funding to go do more with it. Or another area I'm really focused on is virtual reality. I can lead those because I have an interest, and they're different than what our typical consumer would be. But I got to believe 90% of this is business led. And as IT professionals, we need to figure out how to facilitate what they want to do with that technology. And it's not easy with all the integration requirements and security requirements and, frankly, all the overhead we have to put on it to make sure it's safe and usable. But most of the time, I would say it's business driven at this point. And I'm happy with that. I think it's great. That shows we've been successful, right? We've brought technology from Abacuses and Selectrix to they're leveraging it big time. They're pressing us.
Yeah. Hey, CMS just announced getting rid of fax machines. So if you have any Selectrix around there, I'm pretty sure that they're going to want you to get rid of the Selectrix as well. So.
Well, the Smithsonian might like them. But.
So this is a little tougher topic. So you recently outsourced 80 plus jobs. Talk about the decision. Why did you decide to outsource, and how did you make the transition really work for everybody involved?
We're still trying to make it work, Bill, so we haven't succeeded. Why did we do it? The employment rate for technologists in the state of Utah is pretty much a negative number right now. So it's a very, very competitive environment. A lot of what's happening in Silicon Valley, we now have what we call Silicon Slopes. So a lot of it's moving into Utah because it's a favorable business state. There's good talent here, but it really did put a press on us to say, wow, we've got to figure this out. I mean, short term, it's going to be hard, but long term, we got to be in a situation where we can support Intermountain Healthcare. And so that was part of the decision making. The main reason we did it is we believed we needed to get to the cloud more quickly. So we got a partner that they are outsourcing jobs, but that wasn't the primary reason. The primary reason was we needed to get to the cloud, and there was a certain set of people that work for us today that we wouldn't need, right? I don't need a lot of data center people. I don't need a lot of DBAs and a lot of SAs if I've got everything in the cloud. And so it was a better transition from our perspective to get us to the cloud quickly and actually take care of those people that work for us, because at scale, these cloud vendors do need DBAs and SAs and some of the people that we're working with. So that was the thinking, and it's been really, really hard. Hardest thing I've done in my career. And I know some of the people that listen to this are going to say, "What a wuss." I mean, it's only 80 people. We did 2,000. But for me, it's been a challenge to maintain the culture of the organization, to maintain the trust of my employee base, and so we're still working through that. And you used the term transparent earlier. That's been my goal, and it's just to be completely transparent, be completely honest with my people. Lots of them are coming back around. Some of them are probably never going to come around, and they're not going to think I'm anything but a nasty CIO that did something bad. But tough transition for sure.
Yeah, well, that is some of the hard decisions. We want to bring down the cost of healthcare. There's a couple ways to do that. That's one of them is by reducing the labor component, which is always going to be a reality. And then the second reality, I had this same challenge in Southern California. We were competing for talent with Google and Silicon Beach and even Silicon Valley. I mean, literally people were short plane ride up to there, and we had to take, and it was selective outsourcing, right? We didn't go and outsource all 700 jobs. We just looked at specific areas where we were struggling. Like for instance, our Citrix environment, we were struggling to hire new talent, and we finally just threw up our arms and said, there are several really good vendors. We should just start talking to them. They have scale, they have talent, and because they have multiple clients, they were able to service us better. But I agree with you that the challenge with culture, the challenge with walking the organization through that is, it's one of the reasons that it's a leadership position. It's a tough spot to be in.
I got a lot of gray hair for a 40-year-old, don't you think?
Well, I'm wondering how early you started having these kids. 40-year-old. Anyway, so the last question, I do want to touch base. I was down in DC today, looked at George Washington University with my daughter, where you got your MBA from. And just being in DC, it is such an amazing city. And you've had the opportunity to walk the halls of Capitol Hill, work with lawmakers. What would you tell us about that experience, and what can we do as CIOs? Are our representatives really informed? Can we help in the process? How would we be involved?
Yeah, sure. So plug for Chime. I think Chime does as good a job at advocacy on a federal level as anyone for what we do, right? Healthcare and IT. They are incredibly, they have a small team, but they're incredibly well integrated into that environment in DC. I enjoy it a lot. I mean, the thing I've learned the most is that the country's run by 24-year-olds, and that our representatives listen to those 24-year-olds. So, we spend a lot of time talking to those, to their staff, but they're really smart and they're really good people. If we want to make a difference, we're going to have to do these things. These are the people at a federal level that are making decisions, whether it's meaningful use or the use of fire or standards or any of those things. They can do it at a scale that we just can't do as an industry. And so I encourage everyone to get involved that's interested in doing it. And there's certain vehicles. We have our own staff within DC that supports us, but we leverage Chime a tremendous amount as well. So I don't know if that answers the question or not.
Yeah, no, I agree. I think the thing that fascinated me about the couple of congressmen and senators I've chatted with is that they almost start to break down in terms of their specialization, as you would think. You have 100 senators, and some of them are former physicians, and they become sort of the healthcare experts that are informing the rest of their delegation of, hey, here's what this means, and here's how the EHR plays. So not every congressman or senator you sit across from is going to be an expert in health IT, but some of them really are. Some of them really have a very firm foundation for it, and I think when those other representatives have questions, that's what they direct them over. And I love your comment that 24-year-olds are running the world. That's the other thing that struck me, is how many young, energetic kids are running around Capitol Hill. It's unbelievable.
Well, and contrary to what we might have seen with Obamacare and the ACA, where it did seem like a really divisive issue, when you get and work with the congressmen and the senators, they all want to do the right things around health. They don't have the right answers. They don't, and I don't mean they have the wrong answers either. They don't know the exact right answer, but they do want to get to the right solution. And I've had the privilege of working with our Senator Hatch quite a bit, and we're going to lose him, but he was just one of these across the aisle kind of guys. Let's solve the problems. And I see that over and over in DC. And so it's pretty refreshing from that perspective as well.
Yeah. And what I say is modernizing healthcare is a bipartisan issue. I mean, you're not going to find anybody on either side of the aisle that says, let's not modernize healthcare. And so that's what we're doing. Hey, Marc, thanks again for coming on the show. Is there a way for people to follow you? I assume you're on social media, or you're not using the Selectric to type up.
I'm on Twitter. I think it's @Probst_Marc with the C, and you can be one of the other 10 followers. Awesome.
Well, you can follow me at the Patient CIO. My writing on the Health Lyrics website. You can follow the show at This Week in HIT. You can check out the website, thisweekinhealthit.com, and the YouTube channel. Easiest way to get to the YouTube channel is thisweekinhealthit.com/video, and it'll redirect you over to the YouTube channel. Please come back every Friday for more news, information, and commentary from industry influencers. That's all for now.
Thanks, Bill.